Therapist's Eyes. As you might can tell, I am not Chris today. This is Victoria Pendergrass here, and I am with
John Nelson Pope.
Yeah, and we're leading it by ourselves today.
That's right. Chris abandoned us.
Yeah. This is the behind-the-scenes YouTube live look at what we do before we press the record button. Today, we are talking about why do we diagnose? So the three questions that we have today are, why do therapists need to diagnose mental health conditions, and how does it benefit the therapy process? How does a diagnosis influence the treatment plan or therapy techniques that the therapist may choose? And then finally, what steps do you take to ensure a diagnosis accurately reflects a client's experiences and doesn't negatively label them?
Those are wonderful questions. You generated those.
Well, and hopefully we can get to those and answer at least most of
the best of our ability.
The best of our ability by the end of this recording today. Is that it?
That's it.
Does that cover it all? Cool.
Yep.
Well, hi everybody in YouTube land.
Yeah. Oh, today is the 21st.
November 21st.
Yeah.
And next Thursday is Thanksgiving.
Thanksgiving. Do you know what you're having for dinner?
Turkey.
Oh. Guess what we're having?
What are you having?
We're having barbecue.
Whoa.
I'm really excited. It was my mom's idea.
Oh, good.
Yeah. We're doing barbecue. And I can't remember the place she's getting it from, but it's somewhere local. And they're doing day of pickup on Thanksgiving. So we can pick it up Thanksgiving Day.
You know what my vegan
enjoy.
friend's going to have?
What?
Lentils.
For Thanksgiving?
For Thanksgiving, yeah.
Oh. But yeah, so I can't believe it's already almost Thanksgiving.
It is.
But,
there's no podcast next week. Is that correct?
right? Are we doing one next? I think that was up in the
It's
air.
up in the air?
Yeah.
Okay.
I don't think they had decided. We kind of talked about it last week, but I don't think they had decided
Okay.
what they're going to do.
All right, there you go.
Sure. This is a human emotional experience
Let's figure it out together.
in which endeavor to figure out together. What is that the word?
Well, I think that sounds good.
Whatever.
I said
Sorry,
we're
Chris,
not
if
to
we
be,
mess it
we
up.
are not we're not delivering any therapeutic services.
No, not that. The thing that he says at the end of his
Human
thing that
experience.
yeah, which we endeavor to figure out together, right?
Yes.
Okay.
You're good.
Look. Oh, you're gonna have to tell me if we get a comment, because I can pull it up on my phone if I need to.
It's just Chris right now.
Okay. Hi, Chris.
Chris had to defend himself. He's like, I would never abandon my friend. So Chris was watching in. So I guess we'll get comments from the Peanut Gallery with Chris listening. You should be driving, shouldn't you? Why are you on YouTube?
Yeah.
Yeah.
Okay.
All right, we ready to go?
Yeah, I think so.
Deep breath. You ready?
Yeah, sure.
All right. 3, 2, 1.
Hi, welcome to Through a Therapist's Eyes, where you get insights from your home and your car. And today we are talking about why do we diagnose for episode 297.
297. That is excellent.
And I am Victoria Pendergrass, here to replace Chris for the day.
No one can replace
Oh,
Chris.
yeah, sorry. Wrong choice of words. And we have here
John Nelson Pope.
the Pope
Joining
joining us today, as usual. You weren't here last week, though, were you?
No, because my wife was in the hospital.
And she's doing okay?
She's doing okay.
Well, we're glad you're back.
I'm
Glad you're kicking it with me today.
Well, we're going to kick it together.
Yeah.
Or we're going to kick the bucket.
Today is November 21st, right? I got that right? Yep. Of 2024. Thanksgiving around the corner. 2025 is around the corner. It'll be here before we know it. Let's see. We got ratings. What should they rate us on?
They should always rate us at a 5. That's the highest you can go.
Right, 5 stars.
5 stars.
Yeah.
And that will send us up through the different types of platforms like Apple.
Well, yeah, also help the algorithm. It'll help
Right.
us reach more people. And also, we don't really want anything less than 5 stars.
No. That's right.
Yeah. Let's see. What else we got for today? Okay, this is not to deliver any therapy services of any kind.
That's right. But
Correct.
this is to provoke discussion and thought.
Yeah. Today's questions are, let's see. So the title is Why Do We Diagnose? And our questions today are, why do therapists need to diagnose mental health conditions, and how does it benefit the therapy process? 2, how does a diagnosis influence the treatment plan or therapy techniques that the therapist chooses to use? And then lastly, what steps do you take to ensure a diagnosis accurately reflects a client's experiences and doesn't negatively label them? Okay. As Chris always says, this is the human emotional experience in which we endeavor to figure out together.
Oh, that is perfect.
Did I get it?
I think so.
And he usually throws that paper right there and lets it fly. Okay, so what is your experience with like diagnosis? I know we've talked about diagnosis before on the podcast, but like we talked, I think Neil said, like we talked specifically just about like what diagnosis is, but we've never really talked about like why or maybe like how us as therapists use like diagnosis in like our day-to-day sessions with our clients and in the long term.
I think diagnosis has actually been used since the earliest days of psychotherapy, and the early psychoanalytical psychoanalyst used it, and of course they were trying to come up with sort of a template in order to be able to say, well, why do certain people behave the way they do and act? And what's happened is over the years, it's changed. A lot of times the diagnosis, for example, being having homosexuality, and it used to be considered a mental illness, and it was removed from the DSM-5. The DSM-5 first had its roots like in the 1950s. And so it was much smaller volume.
I was gonna say, is that when the first DSM came out? And
that's it. Yeah. Go ahead.
For those who don't know that, it stands for, look, I'm gonna mess it up. It's the Diagnostic and Statistical Manual of Mental Disorders. It's our like book, our quote unquote Bible,
and it gets bigger and bigger every year
for how we diagnose people. And you'd be hard pressed probably to find a therapist that actually knows every single.
No, I don't think you would find anybody.
Yeah. So is that when the first one came out?
Right.
The
early
50s?
51, 52, something like that.
And
so they've had, it was like, no, it was really small.
I was like, I don't think I can reach Chris's that he has here in the office, but yeah, it's now like what, DSM-5 is probably about like this thick.
Right. Now we have the DSM-5 TR. Yeah. And I noticed Chris doesn't have that yet, but it's new. It's
okay, so there's an even when that came out.
It's a revised. It was about 2 years ago.
Yeah.
When the revised version came out, and not a lot of things change.
Yeah.
So it's one of these things where you could just keep adding on and on and on, and eventually we'll have the DSM-5 or DSM-6. Yeah. But the thing is that it's from a lot of different therapists and psychiatrists, psychologists, social workers, mental health counselors, marriage and family folks that contribute to it. For behavioral health.
Yeah, because you're actually the one that brought the topic up
to
me, and then I figured out
you did this.
She
did a great job.
But you're the one that was like, well, we've never really talked about like why we use a diagnosis. So let's start with what exactly is a mental health diagnosis. So this is the definition that I pulled from ChatGPT, which is now my new favorite thing. That I use all the time. But, okay, so it says that a mental health diagnosis is a formal identification of a psychological condition or disorder based on a person's symptoms, behaviors, and experiences. It is determined by a trained mental health professional, such as a therapist, psychologist, or psychiatrist, using standardized criteria from diagnostic manuals like the DSM-5, which we just talked about, or the ICD-11, which is the International Classification of Diseases, which that's more of like a...
That's for all the diseases.
Yeah.
So it's not just...
but that's also, I think, that's more of like a world...
Yes, it is. Like
thing.
a World Health Organization.
Yeah, than the DSM-5.
Uh-huh. Right.
But yeah, most therapists, like you and I, we use the DSM-5.
Yeah, Anglophone countries use the DSM-5
right.
for the most part.
Yeah. If you had to guess, what would you say are like the most common types of like mental health diagnoses?
Oh, I think anxiety.
Yeah, that's the first one that comes to you?
Yeah, depression.
And I think that would probably be the
I think there are more people that are anxious as opposed to being depressed, and then there's the folks that are both anxious and depressed,
which can happen. Yeah.
Right, and these can come from external sources. Yeah. And I mean, you
can have like situational depression.
Yeah. And sometimes people resist the fact that there's also an organic, maybe even a genetic component, familial component to both like anxiety and depression. But most of it is just living in a world that doesn't seem to make sense, and so you have to an absurd world that we live in, and so that's how we kind of react, and we learn how to adapt, and we maladapt a lot of times.
So why do you think that, or what would you say, like, why you think therapists even need a mental health diagnosis to begin with to give to clients? Like, what does that
well mean? I think.
Yeah. What do you think?
This is what I think. I think you have to get a baseline.
Okay.
So you use the DSM-5 or the ICD-11, and what you do is you say, do these fit these symptoms? And these are been a compendium of symptoms for the last 70 years. And so you get criteria, and you get all these criteria, and basically this is what depression is, this is what anxiety is, this is what having a mood disorder is. And you do this to get an initial basis, a diagnosis of what a person is going through, what their experience is, that you take and listen very carefully, and you ask probing questions, and you let the client or the patient talk, and then you kind of run down a list. It's not something you just tick off, but there's also, but you kind of interact with the criteria to help find where this person's coming from. The other thing is, it's hard to sometimes diagnose somebody from the very beginning, and so it might
say the same thing. Yeah.
And the way our insurance companies work is you have to put somebody.
Yeah, and we'll get to that. But yeah, I was literally just about to say that sometimes we can't even give a proper diagnosis for someone on that first session.
For example, mood disorder. You can be very depressed, and that comes off as
depression is a mood disorder.
Yeah, a major depressive disorder. And that's not what it is. It's more like bipolar, know, or something of this.
Yeah. Or something might present itself one way. Sometimes things like trauma and ADHD can be very similar.
Trauma, very
in
much.
Certain aspects, and so
And again, ADHD is an organic.
Yeah, it's a neurological
thing,
or neurodevelopmental.
Right,
disorder,
but. You could become depressed situationally because you're not relating well to the world, or the world's not relating to you.
Yeah.
And so that would make one isolated and might feel depressed.
Do you think, it's not necessarily a question that we posed at the beginning, but out of curiosity, what do you think your typical client's fear is about like diagnosis and how it might be used? And like not necessarily what we do, but what do you think are people's fears, or like what people are afraid of when it comes to diagnoses?
I think people are fearing being stigmatized for it, and they might have a problem. I have a client whose wife is convinced that you don't need to have any therapy, you don't need to take medication.
Okay.
There's no such thing as mental illness. It's just you need to pull up your bootstraps and suck it up.
Yeah.
Interestingly enough, she's had relatives that have shot themselves, or one of them, and committed suicide.
Right.
You know? And she still held on to that belief.
And so, but
so
it was
the
yeah.
husband felt, her husband felt like, I've got depression, I've got anxiety, I need to talk about it.
Right. Yeah, I definitely think that people are afraid of, one, stigmatism, like or stereotyping, like, what depression, that whole, the thing that always comes to my mind is, I don't know if it was for a medication, like a depression medication, but it was like this woman who basically was carrying around this like smiley face mask.
Yeah.
And it was covering like her sadness. She would be out in public and she would like pull this mask out of her purse or whatever and make it look like she was smiling and all these things. And I mean, it was for a medication, but I think like those stereotypical things. But I mean, we've talked about this before that like specifically depression can show up as anger for some people, not sadness. Yeah. And so I think that when people have these stereotypical things, it does maybe create some apprehension into like, okay, well, what does this mean? What will other people think about me? If they know that I'm have borderline personality disorder, or if I have like bipolar.
And they're gonna, and that's the thing is that there's a reverse aspect to it as well, and that is that somebody could wear that as a badge of honor and sort of say, well, I'm not going to change. This is the way I am.
Yeah.
And
there's nothing I can do about it.
And nothing I can do about it. And I think that's a problem too.
And I don't know if this necessarily relates. I think it does, but it makes me think of, I can almost guarantee that this has probably happened to you because you have way more years experience than I do. But I can remember working in the school system during my school counseling internship for my school counseling masters, but then also doing school-based therapy after grad school. And I specifically remember different moments throughout those years where parents would ask me, I would give I would meet with their kid, do the initial assessment, take all my observations, talk to teachers, do all the things. And the parents would make comments about like, well, is this going to show up on their records forever? Is this, I don't want this to show up on their record. Like, I don't want, it to show up on their record that my kid has ADHD or that my kid has depression or anxiety or whatever. And I think that, not a fault of their own, but that comes from like the stigma and like how people view the negativity around certain disorders or certain mental health struggles.
Well, let's get into the military, for example.
Okay.
They have issues with people that might be previously diagnosed with psychiatric issues,
right,
or psychosis. And so you have to be very careful. In the military, there's several levels going on there. Is that one is that they don't want to accept somebody that that's going to be out of commission and not be able to deploy, which is
what are
very
their thoughts?
important.
We might be we get too off topic here, but like, what is that? Because like even things with medication,
with
like
medication,
if you have to, like, for example, and I've talked about this on the podcast before, so that's why I'm open about it. But like, I've been on like forms of ADHD meds for like basically my whole life. And so like,
I think you can get a waiver for that.
Well, I'm just saying, but those are factors into that
factors.
They consider. And so, yeah, I can see how sometimes with those stigmas, people are afraid.
But insurance companies are the same thing, even though they make you diagnose people on one level, which and I say the insurance company makes you do that, is that if you want to get money reimbursed, you do it. But the other is that at the same time, they may be more reluctant to insure you.
So that goes into one of the reasons why we diagnose.
Right.
Is access to insurance coverage.
Right.
So to, I guess, explain a little bit more about that is, so when someone comes to us and they want mental health services, we have like a flat rate for like our initial sessions and our like individual sessions after that first one. So if you want to use insurance, which would typically mean that you get, as the client, pay a discounted rate, right? You pay a copay of some sort. But then that also means that we get paid on the back end, like through the insurance company pays like the full amount to us, but then you only have to pay a percentage of that. And in order to do that, like you said, we typically, if we file with insurance, we have to give a diagnosis that says like, hey, we saw this person. We actually did see this person. And like, here's why we need to continue to see them.
And that's right.
Am I missing anything with
no,
that?
No, and I think the thing is that I think we have to be conservative how we, as therapists, to diagnose somebody as well for the insurance, to the insurance company. Yeah. We want to have a precise and concise diagnosis, but at the same time, we don't want to stigmatize the client so that he or she has issues. Now, if it's something that is in terms of like having a major mood disorder,
right,
a bipolar 1 or bipolar 2, you really, or a schizophrenia or something like that, you've got to do that. But let's say somebody is, you don't overdiagnose. In other words, if you have somebody that is having adjustment problems, you don't want to just say they have major mood disorder or anything like that. You don't
just because just because we want to be reimbursed, we're gonna just slap a diagnosis.
So you have to be very ethical about it.
Yes, so. And hopefully, if you're seeking therapy from a licensed person, they have this ethics-driven mentality of let's not, let's do this so that we're there to benefit the client.
Exactly.
Rather than to pay my mortgage. Which, I mean, I am here to pay my mortgage, but I'm also here to make sure that, like, I do it ethically.
But you have a Maserati, don't you?
Absolutely not. What is that? No, I'm just kidding.
Well, if you have to ask, you don't know.
Right, yeah. Right. Okay, Neil's got the mic. You got something to add?
Quick question. When someone comes to therapy and you talk about diagnosis, what's the timeline to give a diagnosis? So when it comes to insurance, so if I'm coming in here and like, I don't know what my problem is, I have issues, and it's insurance starts covering it, right? Well, to keep going, I feel like you have to have some. So what is kind of like rough idea? Like how long can someone come without a diagnosis that the insurance won't cover it?
Yeah, you got to do it.
Yeah, none. Like we have, so say you come in for an initial assessment for whatever reason. For us to file with insurance that session, we have to provide a diagnosis. Now, from what I've done, we can always change that diagnosis. So say
I've done that.
Say in my first meeting with you, Neil, I'm like, okay, Neil has depression, right? So I put down depression or major depressive disorder as your diagnosis. But then we meet like 2 or 3 more times and I'm like, okay, wait, maybe it's not depression. Maybe it's bipolar, or maybe it's borderline personality disorder or something. I can change that. And then I justify it in the notes that I write afterwards.
So those intake forms become very important, so that way you
Yes.
at least can come in, you have an idea what they're
Establish it.
saying. You can talk to them to kind of either further enforce or basically change
So we even
what you're
do
seeing.
we even do things called like rule outs in our
Right.
assessments. Like I might again diagnose you with major depressive disorder, but then if there's an inkling in there like, oh, this could be something else, I'll put like an R/O for rule out of like bipolar or borderline or something else, so that I can be like, okay, I think it's major depressive, but it could also be or could not also be like one of these other things too.
I'm someone that believes in assessments
Right.
in terms of doing like Beck depression, Beck anxiety, the generalized anxiety, MDQs, and you use those as a baseline of doing this, and so you can also later on, as a person improves, or let's say it's not working, you can give them more assessments later to see should we change the diagnosis.
Yeah.
Because you could have somebody for months, and they said, "Well, I'm depressed," for example, and that's not their issue. I know that's hard to believe, but
Right.
sometimes
It's
it is
something else, right?
And so you have to try a different type of therapeutic intervention.
Yeah.
Right. So going back to that is basically from the time you go start therapy, it's the therapist's job to set a diagnosis. Doesn't make it good or bad. It's just there has to be something there for medical purposes. Plus, I know in the notes, one of the reasons is also helps you set your treatment plan, right?
Correct.
So when
Yeah.
you come in, intake, figure out what's going on, that helps the therapist start the process. So don't
Right.
think diagnosis as a bad thing. As you said, the stigma.
Yeah.
It's very important. It's really beneficial for them.
If you come in and your initial diagnosis from me or whoever is depression, your treatment plan, which is the course that therapists follow to help you, is going to look different than if your diagnosis was ADHD.
When you learned in your school
Oh Lord, yeah.
Okay. about treatment plans,
Oh gosh, that seems like forever ago, but yeah.
I know. But do you take a look every 6 weeks, 8 weeks
At a treatment plan?
at a treatment plan?
Well, my experience has been all over the place. So sometimes, here we're like this hybrid private practice thing, whatever Chris calls it, is ours. We can do our own thing as far as treatment plans, right?
Right.
Now, when I worked and did my did my internship at an agency
Right.
when I was in grad school, and when I did school-based therapy, they had like specific templates for us to fill out for treatment plans.
Right.
That had like goals, had like strengths and struggles, and like all these things listed on it. And that we did have to like date it. You had to like go through and review it with your client and date it every, 6 weeks or so, 6 to 8 weeks or whatever, and like be more consistent. And I think, here personally, I don't necessarily have like a printed paper. It's more of just like an open conversation that I do with my clients as far as like goals. And I might put that in
Exactly.
the initial assessment.
Oh, you give it the human touch.
Yeah.
Which I think that's the downside with some of
I
the
mean, I
agency
literally only
stuff.
have one
Right.
client who likes paperwork homework, and she knows who she is.
I have
but
one.
everyone
I had
else
one person,
does not want me to like
I had a
paper.
person. I had a person come back to me. She came back. Don't give me homework.
Yeah.
I won't do it.
Most people do. I literally have one client who's like, I literally need to walk out of here with a paper of homework every time. But I mean, Neil, and you bring up a good point of like, your diagnosis is going to affect the treatment plan that we create. So we do need to have an accurate representation. And typically for me, again, I don't know about you, John, when it comes to a diagnosis, especially if we're using like EAP, which is Employee Assistance Program, which is like your job will offer to pay for therapy for you. And for those, like, we definitely have to have a diagnosis because it's going through an insurance. I typically have that conversation with my clients. I don't know about you, but I have a conversation that's like, okay, I have to give a diagnosis for insurance reasons, and this is where my brain is at with that. Like, do you have any questions about that? Do you depend. We've talked
No,
about.
we do. I do that.
You do that?
Yeah.
Well, I know everyone
I feel
approaches
we have
it differently.
We have a responsibility to do that. I think it's responsible to tell your clients what you think's going on with them. That's why they're there.
Right.
Is to, and so.
Yeah. So we also have another why is, I think, what do you think about like helping with effective or enhancing communication between you and your client?
Right. Right.
So what do you think like that might look like is for you?
Okay.
In your practice?
Well, when you say enhancing communication, you're saying, why am I doing what I'm doing? I mean, the person, why am I feeling the way I'm feeling?
Right.
And of course, it's the client has to be able to express that and do that. But this may help, a diagnosis may help explain what's going on inside of them. And they can actually get some purchase or actually get a grip as to what is causing their distress. And so that can be very helpful, and that gives them hope.
Right.
Because I think some folks are just absolutely chaos. They're in chaos. And so they need to have something that will help them hold on and say, okay, we're not perfect, but this is what we're working on in terms of a diagnosis, and this is how we're going to approach it and get better.
But what about also not just enhancing communication between you as a therapist and your client, but also like enhancing communication between you as a therapist and the other healthcare providers that your client might be seeing?
I think that's a very important.
Yeah. So, like, again, if I give, sorry, Neil, you're my little your example now. But if I give Neil a depression, a major depressive disorder diagnosis, then he's
more bipolar. But
yeah, for sure. Yeah. But if now he can take that to his PCP, his primary care provider, or he can take that to a psychiatrist, or he can take that to what other ever else healthcare providers, and so that way everyone is on the same page.
Have they gotten back to you, the providers, to say help me get a feeling of what he needs?
Right. Yeah.
Needs. And I've had that both ways.
Yeah, I've had providers reach out to me. I've also had clients specifically ask that I reach out to, that I keep in contact with their psychiatrist or their primary care provider, because that's also going. And then when you throw in things like medication, that's also going to significantly help your provider be able to prescribe you the proper medication, and that can get messy if we're all on different pages as far as what Neil's diagnosis is. Sorry, Neil.
Well, here's another thought in this, and that is that if a person is not compliant with his or her medication, that's going to be key to one's recovery, I think, in terms of...
Oh, for sure.
Because you can... that helps you with the symptoms, but to get to the root of the issues where that person doesn't go back. One of the problems is that sometimes the clients go off, I'm feeling better, and they go off, but they go back to their old stinking thinking.
Yeah.
And so I think it's important to be able to go to another colleague, who's a medical colleague, and say, okay, I don't think I've been given permission to talk to you, and we're talking, we've got all those little waivers done. I think that so-and-so is not using the medication, or it's not as effective as it could be. There's some side effects that they say that they're having that's not helpful. Yeah. And so I think it's important to...
Yeah, I always compare it, and it's funny, I literally was just talking about this to a client earlier today. I always compare it to when you're given antibiotics, how they tell you to, like, take the whole bottle, even when you start feeling better.
Yeah.
It's like...
Same thing.
Yeah. You got to just... But I think when the why being to enhance communication between all these people, and not just between you and your therapist, but between all the...
It's a lingua franca. It's a common language.
Okay. I was like, a what?
A lingua franca.
And then lastly, at least for the why, before we move into the how we use it, the why, I think it helps like provide just like validation and understanding for the client themselves. And we've kind of hinted on that throughout. And like,
So I have a client, a client that said, am I crazy?
right.
And I say, no, you're not crazy. And then an hour later, or next session, she'll say, oh, am I crazy?
Yeah.
My husband says I'm crazy.
Yeah.
And I'm saying, well, tell me how. And
Like,
of course,
yeah.
so.
But then like,
And say,
what
no,
does
no.
giving a diagnosis to her mean?
Yeah. Well, I think it gives her some, again, I use the word purchase. It gives her an idea of saying validation that no, she's not crazy.
Right.
Because craziness is absolutely rare.
Right.
I mean, there's
Right.
insanity.
Yeah.
I mean,
the actual craziness.
Craziness or insanity is rare.
Well, and I think a lot of times because people have been experiencing whatever these symptoms are for however many years, it can be quite refreshing to actually be able to have a diagnosis to put with that. Like the example I always like to give, and I think I gave this when we actually had our episode of talking about like specifically diagnosis, is in internship. I had a client who she was just given a diagnosis previously of depression, and that was on her chart. But she mentioned that like no one else really talked to her about it. No one else really explained like what that meant. And I went through with her, and I remember this so vividly. I like brought out my DSM-5, and I read through depression and like read through the symptoms. And she was like, by the end of it, she was sobbing because for her, it was just this like, oh my gosh, this is like, I've been experiencing literally all of these symptoms that you've been describing, and now I have a name to put with it. And it was like, I mean, I will probably never forget that session, like for the rest of my life. Like it was just so profound.
Let me give you an
like,
example. We had a clinic when I taught at Montreat.
okay.
Excuse me. Actually, I taught it. I ran clinics at two places, at Texas A&M and Corpus Christi, at ULM, University of Louisiana Monroe, and also at Montreat. And I would sometimes, we'd get people that would be basically indigent, couldn't afford for therapy.
Right.
And so they would be going through the public system and mental health system or health center system. And they would come in and they would have, it was bigger than the DSM-5 of their notes.
Okay.
And people would just basically just diagnose, and they would, and this person ended up with like 6 or 7 diagnoses because the therapist didn't do her job or his job.
Right.
And say, okay, let's start over. Let's reassess.
Right.
And so they get piled up with all these things. And so they start having an identity, I think, that I'm broken. I'm so broken.
Right.
So part of this is we have to be very parsimonious and with our diagnosis and make it as clean as possible.
Right.
And make it as a surgical scalpel to cut out the bad stuff and to be able to help. So that's my point is you can
that's probably one of our very like proud moments as a therapist, is like I just instinctively like knew what to do and was like, this like person was given this diagnosis and never really like,
and you explained it, and that took a lot of weight off that person.
And lastly with this is, diagnosis is not meant to label someone negatively. That's not why we use diagnosis. It's meant to, like we've said, guide an effective treatment plan. So now we're going to kind of talk about like how we use it within therapy. Some of these things kind of like go with what we've already mentioned, but I think it's important to not only talk about like the why we use it, but then how we use it in therapy. And we might be crossing over with some things that we've talked about in a previous episode. But so obviously one of the first things, like we've said, is understanding the client's needs. Like you can't really move forward with a treatment plan, like we've mentioned. You can't really move forward with much of anything if we don't have a full understanding of like what your client needs to begin with. Right.
Exactly.
So identifying like the framework, understanding what the client's symptoms are, and this is where like I think being open with your therapist. And being comfortable with your therapist. Like I tell all my therapists, you can get a different therapist. If you don't like who you're with, that is okay.
Yeah.
You can find someone else who you feel like is a better fit for you. And that's okay. Because I think then you're going to be more comfortable to open up about. And then when we have all the information that we can get from you, we're going to be able to provide a better diagnosis, which is then going to be able to obviously help you in the long run.
Yeah. And it's okay to disagree with your therapist.
It is.
Yeah, very.
It is.
Yeah.
It is. Have you ever had anyone openly like
Oh, yeah.
be like, I don't agree with that.
Right.
Sorry, John, I like you, but
Yeah.
And I think that's where we put fillers out, right? Like I might say something and I'm like, did that land? Like, was that, was that a good analogy? Was that, whatever. And I've had people say like, yeah, no, that's not a good analogy.
Yeah. Well,
and I'm like, okay, I'll cut it out. But, go ahead.
Our interest in using diagnosis properly is that you want to do the most good for your client. You want your client to get better. And so if they're still miserable, you're not, and you're using the same old approach, you might say, okay, well, maybe we need to reassess what the diagnosis is.
Well, and one of our questions
because that'll do your treatment.
Right. Yeah. One of our questions at the beginning is like, how does diagnosis influence treatment plan or therapy techniques that we choose? And that kind of goes into the next thing. We've talked about treatment plans, but treatment planning also includes like different types of techniques. So like we said, someone for depression might benefit more from like cognitive behavioral therapy, CBT, or like mindfulness practices or different things like that. Whereas someone with PTSD might benefit more from EMDR or exposure therapy
or cognitive processing therapy. There's
right.
The thing too is that
by the way, EMDR is eye movement desensitization and reprocessing.
Yeah.
Sorry.
So I'm a EMDR skeptic. But, yeah.
But still, like, I mean, that the techniques I'm going to use in my day-to-day therapy with you is going to vary based on your diagnosis. And if I am not able to give a proper, or at least what, based on the information that I have, a proper diagnosis, then the techniques that I use with you in therapy, you might be like, what? Why is she doing this? Like, this is not effective,
Well, let's use another example. Is sometimes there's a borderline personality disorder.
Yeah.
And that's basically a core, who you are is your identity. And part of that is there has to be some sort of reality testing that a person has. And so they have dialectical behavioral therapy.
Right.
And to be able to
DBT.
put DBT. Yeah. And so that's a good way of, and so you could treat depression, their depressive symptoms with it, but it's very effective with
ineffective or effective. Okay.
Effective.
Yeah.
Okay. So I think that's important that you have the right therapeutic model working, and so that their improvement can happen quicker.
Well, and I also think,
and permanently.
And I don't know, I might be off base here, so tell me if I am. But if I were, say, like someone was seeing you for a really long time and you gave them a specific diagnosis, and then for whatever reason they moved, you moved, whatever happened, they had to got a new therapist. Well, typically they're also taking their diagnoses with them. And so like the next therapist hopefully is still going to do their own assessment and like come to their own conclusions, whether or not they agree with previous diagnoses, but it kind of gives like a starting point of like where at least what like some history as far as like what's been
there. And
there.
I think that's why client notes are very important because the person can he may have let's say the person gets the wrong. Let's say the therapist, we get it wrong, have the wrong diagnosis, but has excellent notes. Then they could the next therapist could see it and say, okay, well, this gives me some insight as to what is going on with this person. So,
for sure.
Yeah. So I think that's important. I think it's another thing, and we don't pull them in as much as we could because I think sometimes people are their family members.
Oh, pull family members in?
Yeah, pull them in.
Yeah, I mean, one of the things I used to really enjoy about doing therapy in the school system, like being a school-based therapist, which for those of you who don't know, and I've explained it before, but a school-based therapist is someone who's like embedded into a school full-time typically or part-time, and they do just mental health therapy but in the school, so like parents don't have to worry about driving their kids to therapy or whatever happens during the school day, which can actually be very beneficial for like low-income families, people that have trouble like traveling, don't want to take their kids out of school just to go to therapy or whatnot. But one of the parts that I used to really like about it is because I had access to so many people who had interactions with these kids. So like, say I had a 4th grader, well, like I could talk to their teachers. I could talk to their specials teachers. I could talk to the assistant principal or the principal, or, if they had an IEP or a 504, like I had so many people and I would try to do that every chance I got. Like, every time I had an assessment, I would try to go and talk to these people who had like these daily or weekly interactions with these kids just to give me more of a bigger, better picture of like what is coming from. I'm not only talking to the parent, but then I'm also talking to like, sometimes not a lot. I didn't do this often, but sometimes I would like talk to their siblings and like, talk about their relationship with their siblings and like get their siblings' point of view, but definitely talk to the teachers, like having access to all these people. And I think that's probably something I miss about being here in private practices. Not that I can't do it. It just obviously takes a little bit more effort and a little bit more work because I'm not in the school building.
And sometimes the client doesn't want to involve the family. And I think
So part of being a school-based therapist is they signed paperwork so where I could talk to the teachers and everything without having to like get special clarification from the parents. But yeah, here like we would have to get a ROI, which is a release of information form signs, and the parent would have to be okay with us doing that. But I do think that it could be used a lot more than the way that what we do with it, for sure.
Because they could be allies in terms of helping and give further insight as to why the person maybe is acting the way they are.
I mean, I'm even thinking I had a 20 to 25 minute conversation earlier this week with a parent about her son because they were about to have like a 504 meeting, and we talked about like strategies that she can suggest for the 504 accommodations, like for their upcoming meeting.
Okay.
And
would you explain to the listening audience, a viewing audience, what a 504 is?
504. Okay, a 504, I'm going to hopefully explain this to the best of my knowledge, is a 504 is a plan that can be put in place for kids who have mental health or like behavioral health issues and struggles at school. And then because of that, accommodations can be put into place. So for example, if Billy Bob has a ADHD diagnosis, he can, they can apply for a 504, see if Billy Bob meets the criteria, the qualifications for it. If he does, then he can get access to accommodations, which might mean things like preferential seating in the classroom to help with focus.
There we go. And I think this is the key that what we're talking about. Diagnosis is very helpful this way.
And like he wouldn't have access to that if he didn't have an appropriate diagnosis from a mental health
ADHD
professional.
is one of the things that we've been able to to help with diagnosis. Sometimes with I do a lot of Social Security disability.
Yep.
And so, and help them with that vocational rehabilitation. They don't call it that anymore, but it's they changed their name. But
well, and even if you don't necessarily, and that goes way into like college and grad school, you can have access to specific accommodations if you have certain mental health or behavioral health like diagnoses.
Well, the ADA too
is
another thing, and a lot of times, unfortunately, the big organizations they give lip service to accommodations, but you have to go through all these hoops, and it's also very labor intensive, and so and you have to have a therapist that is willing to go and stick with it, even for months, to be able to do this.
For this one student in particular, like I had to, submit like a letter about his diagnosis and about how I came to that diagnosis and blah, blah, blah. Like I had to put it all out on paper. And obviously the mom was okay with me doing that and sending it. But, for them to like go into consideration for if I have a floor plan, and which now this kid has. So, okay, we got other things like the big one, goal setting. That is how that's how we're using diagnosis and to create goals. Good old goals.
Did you say goals or goals? I'm teasing you how you pronounced it. Goals.
Goals. Okay, don't make fun of my accent.
Okay. Well.
Setting goals. Okay, what can you tell me about setting goals, John?
Well,
and how we use diagnosis to do that.
I like to set goals with the clients over a period of 12 weeks, 12 to 16 weeks. But sometimes it could be shorter. We could do short-term goals, middle goals, and long-range goals.
Right.
Where you get there, and diagnosis is. For example, a person that might be having, let's say they have, I'm trying to think in terms of having anxiety. Okay. One of the gold standard for anxiety is CBT. The Aaron Beck. And cognitive behavioral therapy.
Yep.
And there's a definite process that you do with a workbook, or you can use a workbook like the anxiety workbook.
Oh, I have plenty of
worry
More
workbook.
specifically for kids, but
yeah. Mine are for adults for the most part, and it helps to set a treatment plan for them. It helps them go and do exercises. They have to do it with intentionality.
Right.
And again, it's what people don't like doing, and that's homework. But
usually I don't know about you, just a little tidbit here. I usually don't call it homework. I call it usually like exercises or practice or something along those lines, so that it's not like we're not back in elementary school and I have to like complete this homework sheet or whatever. But sometimes if I do, I don't give it out a lot. But if I like physical paperwork, I don't necessarily.
I think
give
people
out a lot,
will use their workbooks a lot more, because then they won't look at it as homework. They'll look at it in terms of you're participating and you go over it with them. But the motivation is to have the person be motivated for it.
Well, and I mean, you're not going to have, or at least I would think, you're not probably going to have a goal of, I want to read 200 books in 1 year.
Which you have.
I'm almost there. Okay. I'm at like 197.
Right.
Okay. Neil, don't give me that look. Okay. I might have a slight problem. But anyways, like if I don't want to set that as a goal if my diagnosis, or if I'm working on like depression, or if I'm working on, like you want your goals to reflect.
You're right.
Like now the reason that I might be trying to read 200 books in 1 year might be attributed to the depression or vice versa. But like you want it to be relevant, and that's the whole, like, we grew up with the whole SMART goals or whatever. You know what those are?
No.
SMART goals. Okay, SMART goals stand for like specific, measurable, attainable, relatable, and then like time
That's
management
right. Okay.
or whatever. And so like, yeah, you want your goals to be relevant to what, what it is your diagnosis is. Like, it's got to make sense,
Yeah, this is one of the things in setting goals with somebody that is deeply depressed.
Yeah.
Deeply depressed. They need to get out and exercise. They need to go out and smell the fresh air. And a lot of times they don't do that because they don't have the energy.
I'm like, yeah, they literally can't get out of bed.
So
like,
how can you help them with that motivator? How does that volitional thing
Well, and I think that can be maybe a goal down the line.
Right.
But we got to make it like smaller, more obtainable things to get there.
Okay. Yes, we need to go on.
Okay, so we have also things like, and we mentioned this, communicating with other professionals, so we won't talk, we won't continue to talk about that. Tracking progress. Like, you can like measure improvement over time and use like diagnosis within that.
Right. So you can measure the symptoms and you could say, is there a decrease? With PTSD, they give you is it the PCL-5 or the PCL-10?
Something like that.
Basically like that, and I don't need it. Okay. So,
but yeah.
So, and you do that, sometimes you can do it every treatment, or every session, or you could do it every 5 sessions. And you say, well, is this person having less post-traumatic stress disorder symptoms?
Right.
And so you can have it measurable. So that's evidence-based, but at the same time, it helps that person say, I'm improving.
Right. Great points. Again, we have providing validation, which we've talked about, and understanding. Also, I didn't think of like access to resources. Again, we kind of mentioned that with like the 504, right? If you have a proper diagnosis, you might have more access to accommodations.
Get a person
and things.
into Voc Rehab, for example, would help them have more job opportunities or education opportunities.
Right. Yeah, and we're not just talking about like when you're in like secondary, like school. We're talking about like in your career field, like you might be able to access specific accommodations and specific resources if you have a diagnosis that like supports that and backs that up.
For test taking, that's another one. For the GREs or the SATs or the ACTs.
Or even things like the NCE, which is the National Counselor Examination, which we had to take.
Oh, yeah.
So, yeah, like, and access to resources is going to be more of that, like, whether it's community, whether it's groups, whether it's, like, there might be certain groups. We talked about groups last week. You weren't here for that, but we talked about groups last week. And, like, you might be able to have access to being involved in more of, like, a closed group if you have a specific diagnosis to, like, be a part of that group. Okay, and lastly, professional responsibility. And we've kind of talked about this throughout. The ethical and clinical guidelines that we follow as therapists to document diagnoses, whether we're filing it with insurance or whether it's someone who self-pay and is not getting filed with insurance. Like, it's our responsibility to...
What's our standard of practice?
Yeah, to give the best care. And part of that best care is giving, like, the best of our ability in diagnosing.
Right.
Neil?
Well, we've had a comment from our stalker. From Chris. One, he did start talking about changing things around. He said I have had people in therapy for a year and trauma is found, thus the diagnosis changes to PTSD.
Yeah.
So as you go in, you go one thing, you find out more history, that changes. But then we can probably close on this question from Chris.
Okay.
Is diagnosis a science or an art?
Ooh.
I think it's both. And I will say because it's statistics, it's data, it's accumulated knowledge that goes in there, but it's also an art.
Yeah.
And so basically...
there's a reason we had to go to school.
Right. It's practice, and it takes a sense of nuance.
Right.
And that's why we're professionals.
Correct.
It's not that we want to brag. Oh, look at me! I've got this degree, or
Right.
But it is we have
The training.
the training, and we've learned, and we've had experience that would help us with doing this, and so you can start to get a feel for diagnosis. I think.
Yeah.
If it was very hard for me to do diagnosis a long time ago.
Yeah.
It's not
it's
so
very
hard.
true. I mean, yeah, you
It's
just
not
definitely
as-
have to have a comfort with doing it. You have to have a confidence that like goes with it, and knowing that you're making this
you have to-
decision.
that's right. And sometimes you're backed up to a wall, and sometimes the legal system doesn't always appreciate that. It's
Right.
Because I remember one of my first cases,
Yeah.
I was called as a witness. And determining with somebody's, this is in Texas, and determining whether that person is a competent parent.
Gotcha. Yeah, I mean, I would
was
definitely
awful.
agree. I would definitely agree that with you, and say that I think it's both a science, but it's also an art, and like how you deliver it, and like how you come to like what matches for each person.
Right.
So I do want to end with again reiterating that diagnosis is not meant to label. And while diagnosis is a useful tool, therapists often emphasize, or we as therapists often emphasize, that individual is beyond their diagnosis, and focusing on the client's unique experiences and strengths and personal goals.
Yeah.
Any last minute
Yeah. Just
mic drop?
Yeah, you're not your diagnosis.
Yes, you are not your
You
diagnosis.
are you.
You are you. You are John. I am Victoria. Neil is Neil.
And Chris is
And Chris is Chris. Okay.
So
Remember, take care of yourself. Diagnosis is not a scary thing. And take it easy. Have a good week.
take care.